Thank you to SAGES and the session chairs for the opportunity to speak today on the gold standard operation for reflux in an obese population. Gastroesophageal reflux disease is one of the most common GI disorders with a prevalence of about 20% of adults in Western culture. Morbidly obese patients are at a greater risk for developing this disease, likely as a result of increased intra-abdominal pressure, higher risk of developing hiatal hernias, and other hypothesized factors such as an increase in hormones like estrogen. Given conflicting results of traditional anti-reflux surgery in patients with obesity, many advocate bariatric surgery to simultaneously correct reflux, obesity, and other weight-related comorbidities. In this presentation, we will look at some of the data on the effects these specific operations have on GERD. But first, we need to frame the discussion. As with the non-bariatric literature on this topic, it is important to look at and understand how GERD is defined in these studies and to ensure we make appropriate comparisons. Are we defining GERD by looking at medication use, symptoms, presence of esophagitis, or objective measures such as manometry and pH studies? Similarly, are we determining resolution based on medication use, validated patient surveys, or objective data? And are we evaluating outcomes in the short term or long term? The impact of bariatric surgery on the development, resolution, or exacerbation of GERD remains an evolving topic of debate, as the study designs and data are quite heterogeneous, and we need to keep this in mind as we review the existing literature for each operation. Let's start by looking at GERD outcomes after Roux-en-Y gastric bypass. In 1991, the first report on the use of Roux-en-Y gastric bypass to treat reflux was published. After a mean follow-up of 20 months, 97% of patients remained asymptomatic, and 3% only had mild symptoms controlled by occasional antacids. In another study, the authors evaluated outcomes in 152 out of 238 patients who underwent gastric bypass for obesity, but who also had GERD. Both symptoms and medication use were markedly reduced at 6 months. Over 80% of patients had no GERD symptoms, and 97% of patients did not take daily medication. Finally, in a prospective multi-institutional observational study involving 109 hospitals and over 28,000 patients, the authors reported up to 1-year outcomes comparing lap sleeve, lap band, and lap Roux-en-Y gastric bypass. They found that 70% of bypass patients achieved improvement or resolution of GERD symptoms 1 year postoperatively. Matalosso's group studied 86 patients who underwent open Roux-en-Y gastric bypass for obesity, both preoperatively and 6 months postoperatively, evaluating them using the Montreal Consensus for GERD symptoms, endoscopy, 24-hour pH monitoring, esophageal manometry, and barium swallow. They found that Roux-en-Y gastric bypass ameliorated esophageal and extraesophageal symptoms, improved or healed esophagitis, reduced esophageal acid exposure, and esophageal motility was not significantly affected despite surgery. They then re-examined 53 of these patients 3 years later and found further improvement in symptoms, reflux esophagitis, and esophageal acid exposure. Thus, the authors concluded that Roux-en-Y gastric bypass is the procedure of choice to resolve obesity and GERD in patients with a BMI greater than or equal to 35. The positive effect of bypass on GERD in obese patients is not universal in all studies, however. For example, in a recent study from Sweden, the authors analyzed reflux before and after Roux-en-Y gastric bypass in over 2,400 patients for a median follow-up of 4.6 years. They found that GERD persisted in 48.8% of patients within 2 years of gastric bypass and up to 10 years after surgery. In addition, the data suggested that the strongest risk factor for postoperative GERD was high-dose preoperative acid suppression. Despite these findings, the general consensus in the literature is that Roux-en-Y gastric bypass is an effective operation for reflux in obese patients. Let's turn our attention now to another bariatric operation, the lapped sleeve gastrectomy. Laparoscopic sleeve gastrectomy is now the most commonly performed bariatric operation in the United States, yet the impact of sleeve on reflux remains unclear. While many patients experience resolution or improvement of GERD symptoms after sleeve, studies have shown that a subset of patients experience worsened or de novo reflux symptoms. There are many potential reasons for this. First, it has been suggested that the anatomic changes of the sleeve configuration can worsen reflux, namely reduced distensibility and compliance of the residual stomach, leading to heightened intragastric pressure, and disruption of the GE junction, angle of His, and division of sling fibers, impairing lower esophageal sphincter function. In addition, specific technical factors may also contribute to GERD, including the creation of an overly tight sleeve or leaving excess fundus behind. Data on reflux outcomes after sleeve are mixed. For example, in one systematic review of 11 prospective and retrospective studies encompassing over 1,000 patients, 7 studies identified a decrease in GERD prevalence, while only 4 studies identified an increase. Yet in another meta-analysis of 46 studies, the authors found that 19% of patients had worsening reflux, while 23% developed de novo reflux after sleeve gastrectomy. The long-term prevalence of esophagitis was 28%, and Barrett's 8%. In addition, 4% of patients required conversion to Roux-en-Y gastric bypass due to severe reflux. 2 well-known randomized controlled studies compared sleeve and bypass, and they also showed mixed results. The SM-BOSS trial demonstrated higher incidence of GERD and decreased rate of improvement or resolution of reflux symptoms after sleeve compared to bypass. That study also reported de novo GERD in 31.6% of patients after sleeve versus only 10.7% in bypass patients. On the other hand, in the SleevePass trial, de novo GERD after sleeve was only 9.1% after 30 days and 5.8% after long-term follow-up. As can be seen here in the BOLD trial, 56.6% of bypass patients demonstrated improvement of GERD symptoms postoperatively, while only 41% of sleeve patients demonstrated improvement. Compared to bypass, a greater percentage of sleeve patients also developed worsening symptoms postoperatively. And in the American College of Surgeons Bariatric Surgery Centers Network study, only 50% of patients with preoperative reflux undergoing sleeve had resolution or reduction of symptoms, as opposed to 70% of bypass patients, as discussed earlier. As can be seen, the collective data on the effect of sleeve gastrectomy on GERD symptoms has not been as consistent as with the bypass operation. Nevertheless, with careful patient selection, there are likely key scenarios where sleeve can still be the bariatric operation of choice. Before we summarize the findings, there are 2 related disease processes that should be mentioned in light of this discussion. Persistent esophageal acid exposure leads to esophageal mucosal damage and intestinal metaplasia known as Barrett's esophagus. A small percentage of these patients will progress to develop esophageal adenocarcinoma. In Roux-en-Y gastric bypass, the gastric remnant is preserved and can be used for reconstruction if esophageal cancer develops and an esophagectomy is required. In fact, in a small series of gastric bypass patients, complete or partial regression of Barrett's esophagus was actually demonstrated postoperatively. As such, most experts consider Barrett's esophagus a contraindication to performing sleeve gastrectomy due to its potentially inferior effects on reflux and the fact that it eliminates the stomach as an option for esophageal reconstruction. On the other hand, other experts argue that sleeve is an acceptable option for patients with Barrett's in the absence of dysplasia, especially in older patients, given the overall low rate of Barrett's progression to cancer and the effectiveness of new surveillance and endoscopic ablation techniques. The controversy on this topic persists given the lack of good long-term data. Acid may not be the only culprit for GERD symptoms after gastric bypass, and bile reflux into the pouch can occur and has been reported. However, in general, a routine 100 centimeter alimentary limb helps prevent this process in gastric bypass patients. Yet bile reflux may be of greater concern in patients undergoing a newer operation known as the one anastomosis gastric bypass. This faster operation is gaining popularity and involves the creation of a longer gastric pouch with a single anastomosis between the pouch and jejunum and an average distance from the ligament of Treitz of 250 to 350 centimeters. While the risk of GERD may be lower with this operation, bile reflux is a real concern and could result in postoperative GERD-like symptoms. There is a paucity of long-term data on this topic. For now, what we know is that bile reflux is seen on scintigraphy, but the clinical significance remains unclear. Let's now summarize this presentation by looking at the potential mechanism of GERD improvement in the more commonly performed Roux-en-Y gastric bypass and sleeve gastrectomy. By and large, Roux-en-Y gastric bypass is considered a very effective anti-reflux procedure in obese patients. The operation plays a role in significant weight loss without altering the anatomy of the lower esophageal sphincter or increasing intragastric pressure. The small gastric pouch limits potential esophageal acid exposure. And there's decreased bile reflux with the long roux limb and gastrojejunal anastomosis. On the other hand, there are quite a few potential mechanisms for GERD improvement for sleeve patients as well, including reduction in parietal cell mass and acid production, the gastric anatomy resulting in accelerated gastric emptying and reduced gastric volume, resultant weight loss that also decreases intra-abdominal pressure. And finally, some studies suggest that there's an increase in compliance and restoration at the angle of His over time, and this may improve early postoperative reflux symptoms. So in conclusion, what is the gold standard operation for reflux in an obese population? Overall, studies demonstrate improvement or resolution of GERD in the majority of patients undergoing bariatric surgery. In addition, there's little evidence beyond expert opinion to support the notion that pre-existing GERD should exclude patients from undergoing sleeve gastrectomy. Thus, in patients with mild or well-controlled GERD, most feel that with adequate patient counseling, laparoscopic sleeve gastrectomy is an acceptable option, especially if contraindications to Roux-en-Y gastric bypass exist. In most cases, reflux after sleeve can be effectively treated with medical therapy. And in those patients who develop debilitating symptoms of GERD, they may require conversion to bypass. And in patients with severe GERD or Barrett, Roux-en-Y gastric bypass is likely the better option. In addition, there are some strategies that can help mitigate the risk of postoperative reflux. First, be aggressive in identifying GERD and hiatal hernia both preoperatively and postoperatively and manage accordingly. In fact, studies where patients underwent concurrent hiatal hernia repair and sleeve gastrectomy tended to report less postoperative GERD symptoms. Next, again, underscoring the importance of preoperative counseling with sleeve patients who have reflux disease. And finally, we need to continue looking for answers with the aid of well-designed long-term studies. Hopefully, future research will help us develop guidelines and protocols for how severe GERD is defined, the size of hiatal hernias that mandate concomitant repair, identification of key patient characteristics that can aid us in predicting whether they will develop worsening or de novo GERD postoperatively, and finally, further study of the effect of bariatric surgery on Barrett's, including evaluation of long-term endoscopic findings after sleeve gastrectomy is needed. Again, thank you to SAGES for the opportunity to speak today.